There was a time when a cholesterol of 300 was normal, and then 250, and then it just keeps coming down. So now we still say 200, but this LDL goal with respect to preventing heart disease just continues to drop.
So I'm so excited to have Dr. Christopher Davis on the podcast today. He is a triple board certified interventional cardiologist. After more than a decade in a traditional practice, he began developing proactive, data-driven approaches to cardiovascular health. There are a few cardiologists that have boldly said that fish oil does nothing, but you mentioned including fish oil.
There are tons of benefits and tons of studies that show the benefits with triglyceride lowering, neurocognitive health in fish oil. And if we give too much fish oil, we can start to use a lot of these enzymes up.
I want to go back to toxins, but then also let's talk about this phospholipid therapy.
What makes us sick and what makes us get old is largely the stuff that we're exposed to. There are very few people who don't have any of these toxins that are elevated to a certain extent. And the people, interestingly, that typically have the least amount of these toxins are people who have been using an infrared sauna. I'll tell you, the number one tool I feel from a longevity perspective is the sauna, okay, for so many reasons. But
I am so excited about this podcast. You and I have been talking about it for a while, but I also haven't had a super in-depth conversation on cardiology yet.
Fantastic. So we'll have it today.
We're going to have it today. So I'm so excited to have Dr. Christopher Davis on the podcast today. He is a triple board certified interventional cardiologist and fellow of the American College of Cardiology. His expertise spans conventional and integrative cardiology with a focus on prevention, performance, and longevity. After more than a decade in a traditional practice, he began developing proactive, data-driven approaches to cardiovascular health, combining advanced diagnostics, lifestyle strategies, and innovative therapies to optimize long-term outcomes. Welcome to the podcast, Doctor.
Thank you. So happy to be here. Excited to try to jump in. We've been trying to get this arranged for a while, so I'm so excited to be here. Thanks.
I know, and we were just talking for like 30 minutes before, and we're like, we need to start the podcast now.
Right.
But
we would have gone on, and none of it would be recorded.
I know, exactly. Okay, well, we know that cardiovascular disease is the number one killer for both men and women, right? So if we're thinking about a longevity protocol, we have to be prioritizing cardiovascular health. But I want to jump in because I feel like it's so nuanced and you have such a different approach. Like, you know, proactive cardiology is not really a thing right now, is it? Like, how did you come to the idea that you wanted to be proactive about this? I mean, it is, I suppose we do prescribe tons of statins, which we'll talk about, but you're doing things so differently. You're taking like a whole body approach. So tell me a little bit about that.
Yeah, I mean, I think that's the part in medicine that's tough because we really do need to look at each individual comprehensively. It's starting, I mean, if I'm just dealing with the heart, then I'm missing so many other things that are affecting the heart, so many other conditions, the gut health and their thyroid, and so many other parts that we're missing with respect to kind of how it affects the heart. For me, what really started this was kind of just understanding as an interventional cardiologist, that's a cardiologist when somebody's having a heart attack or they have blockages in the artery. We go in, we put a stent in and we open up the artery and we call it a win and say, hey, we saved you because we put that stent in. But the problem is what caused that disease in the first place, right? What caused that blockage? What caused the heart attack? Is a stent going to prevent a blockage from coming back or preventing another heart attack? And after practicing for about 10 years, cardiology is super exciting. Interventional cardiology is super exciting. But after about 10 years and still doing everything that we're told to do, right? And telling your patients to exercise and lose weight and putting them on a statin and a beta blocker. And yet they continue to come back with the same problem. For me, I started to realize that, okay, we're missing the forest for the trees here. There's something more to truly helping patients. And I just started to do my own research at that point, trying to figure out, well, what does that mean? What is truly getting to the root, or how do I truly help these patients not come back? Mm-hmm. And one thing I realized in doing that is I didn't know a whole lot about nutrition, right? As a cardiologist, and you tell somebody you need to lose some weight, right? You need to go on a diet, you need to exercise. Well, I don't know how many times I said that. Yeah. But did that truly help? And I think about it now, did that truly help my patient? Probably not in the least, okay? Because most of the time, what going on a diet and losing some weight for everybody is different, and what works for everybody is going to be different too. So giving them no even basic plan, more or less something that's more individualized for them. So anyways, I mean, my role at that point was to try to figure out kind of what do I need to do and how do I kind of help these patients. And so I just started a nutrition practice, really. My initial kind of introduction to kind of functional medicine, if you will, integrative medicine, I just started doing nutrition stuff, telling patients to stop eating gluten and take some vitamin D and add some fish oil. And voila, lo and behold to me, these patients were starting to just get incredibly better with simple things just like that, simple recommendations. And so at that point, I knew, okay, I got to do this a little bit different. And so that just led to lots of other rabbit holes, and we can talk about all the other stuff. But that was kind of the start of everything, me seeing how much of a difference just this basic nutrition helped the clients with respect to their blood pressure, diabetes, metabolic syndrome.
Yeah.
I mean, it was pretty amazing.
Well, let's stick on a few of those topics. So nutrition, I mean, of course, we all know that we need to eat healthier and exercise, right? But exactly like you said, what does that look like? Maybe from a baseline, let's assume that everyone will have small nuances, but what would a heart healthy diet be?
Yeah, so that actually is, and if we want to be, let me just go very general first, okay, and then I can go down into the more specifics, because I think the individualization using genetics, and I use a lot of genetics for everything. Every client that comes through my door gets
Right.
genetic testing, so we can talk about that. But I think just from a basic perspective, eating whole foods, not processed foods, is going to be very important. Making sure that we're getting good organic foods, making sure we're eating lots of fruits and vegetables. I'm going to kind of very kind of high level here, and not consuming lots of processed sugars, refined foods like that are going to cause more oxidative stress in the body. So that's kind of a very kind of high level what it looks like. And people will often talk about, okay, we're fat, we got to go no fat and that type of thing. Well, at the end of the day, I mean, most of these low fat or no fat products oftentimes have lots of these carbohydrates or sugars and processed, and they cause more issues than actually eating some of the fat, the healthy fats, so to speak. And so, certainly we need fat in our diet, and fat has a lot of good roles. We'll talk about cell membrane health and fatty acids and how our body uses those as well, how the mitochondria uses fatty acids. So fat's not necessarily a bad thing, okay? It's just understanding the types of fat and understanding also your predisposition. When we get more into the nuances of it, saturated fat, is it good for us or bad for us, right? Okay.
We need to know.
So, okay. At the end of the day, okay, it really depends. And there are some very specific, and I have some great cases. And when I do talks, I always show these cases. I have some great cases of, people who didn't do their genetics and then thought that they were going to go do a carnivore diet or the ketogenic diet. And these diets had higher amounts of saturated fat there. And some people did great, but the people who don't do great, there are a few genes, and if your audience is listening, things like ApoE and ApoA2 and TCF7L2, these are genes that if you eat too much saturated fat, a couple things are going to happen. Your cholesterol, the small dense particles, your total cholesterol, your inflammatory markers, they're going to go through the roof, okay? And in fact, one of the things that I learned in doing this is that traditionally we're taught that, okay, if we eat a higher fat diet, then a lot of things happen. We become more, we can deal with issues of metabolic syndrome, triglycerides go down, HDL goes up. Well, there are people that if they have these genes that I just talked about, if you're eating a high saturated fat diet and you have a TCF7L2 gene variant, then the triglycerides will go through the roof. And guess what? I've seen it probably 5 or 6 times now. Like, it's exactly what happens. And so if you get the genetics beforehand, I know not to tell those people who have these specific gene variants, and there are a few more, that, okay, that ketogenic diet with a higher saturated fat, or certainly a carnivore diet with higher saturated fat, is not going to be good for you. And so you can actually, that part of individualizing your approach to every patient, I think, is incredibly important, because we got all these studies that say, okay, this is best and this is best, and everybody decides, hey, this is what I read online, and so I'm going to do this ketogenic diet, right? That's not the right approach, right? It 100% is not the right approach. And I got burned doing this, because I got on board with this thinking the ketogenic diet was the cure to the world, right?
Yeah.
Well, it helped a lot of people with diabetes, and it still helps a lot of people with diabetes and metabolic syndrome. But you can get into a world of hurt if you're doing a ketogenic diet and you have those gene variants. And I've seen it, and it happened to my patients, and I had this, oh my gosh, okay, what am I going to do now? And I had to understand it. And so that's why I use the genetics on every patient.
I love that. I mean, I am a huge proponent of that. I've had probably 7 different genetic tests, and everything that I'm doing is trying to be based around genetics. So I love that. I mean, in a general sense, though, so we've seen so many different studies. Meat is going to definitely cause cancer. I know this is a little bit out of the cardiac realm, but new studies showing that, with the right type of meat, it might not be as bad. What are your general thoughts about like high quality animal proteins?
Yeah, I think that, again, it certainly is, the data is all over the spectrum. Okay. I tend to, as I look at my clients, and when we're measuring oxidative stress markers, and when we're looking at all these biomarkers, what I'm doing is I'm trying to look at, okay, how does, good quality meat affect, all of these separate biomarkers, and what I feel, and whether this is right or not, okay, and because again, as you look at all the literature there, you can find whatever you want to find with respect to the meats causing cancer and TMAO and all these type of things, right?
Yeah.
For me, I'm looking at my patient, how they feel. I'm looking at their biomarkers. I'm measuring vascular health with specific parameters, vascular compliance and things like that. And I think with good quality meats, I think they are. I think they are very important. I think they're important with respect to muscle. And I'm sure. I mean, we've heard lots and lots about the importance of muscle and avoiding sarcopenia. They are important for a lot of the micronutrients, the B vitamins, right, that we get in from meats. And a lot of times, a lot of people who are not eating meat are tremendously B vitamin deficient, which is super important. Obviously, we know about methylation and things like that. So I am a big believer in good quality meat. Now, we can also go and we can start to debate the amount of protein, right? And are we recommending too much protein? Do we need to minimize the protein because of the load on the kidneys? Again, we can read. I mean, I've tried to kind of figure this out myself too. But guess what? We can find data on all from each of those spectrums. So.
Yeah.
From my perspective, again, I'm trying to just look at, we're monitoring the kidney function. We're looking at other parameters with respect to how the client is doing. And so, I don't know. I think that somewhere for me, I'm typically around 0.8 to 1 milligram of 1 gram of protein per pound of body weight. Now, whether that is too much or not, people will debate that.
Yeah. So you talked about some of the parameters that you're looking at for each patient. Can we talk through some of those? Because I feel like a few things as it relates to, the common ones, right? LDL to HDL, then the ratio, what's most important. And also, haven't these ranges shifted a lot over time?
Yeah. So we'll start with the last part of that question first. Yeah. What a normal cholesterol is has shifted over the course of the last 30, 40 years. There was a time when a cholesterol of 300 was normal, and then 250, and then it just keeps coming down, down, down. So now we're kind of, with respect to the total cholesterol, we still say 200, but this LDL goal with respect to preventing heart disease just continues to drop. Okay. I find that very problematic. Okay. First of all, there are many different types of LDL. LDL comes in many different, in sizes, right? And certain particles, small LDL particles are much more atherogenic. They are much more apt to cause problems with the blockages in the arteries, atherosclerosis. And so what's important is looking at, how much of the LDL is actually small, dense LDL. How much of the LDL is actually a particle called lipoprotein little a. I'm sure that's something that's really coming on the radar these days. And it's been around for a long time. And we've known that is a true, real independent risk factor for heart disease. The people who have a father who had a heart attack at 51 and his brother had a heart attack at 47, and then their grandfather had a heart attack at 52. That type of history is typically a history of somebody who has an LP little a, lipoprotein little a elevations, which is primarily genetic, right? I mean, we don't eat the LP little a up, and you can't eat your LP little a down. Okay.
What is LPA little a actually measuring?
So it's actually measuring. It's actually an LDL molecule with an ApoA connected to it. Okay. So it is an LDL. It's a type of LDL molecule. So when we were talking about LDL, okay, if a lot of that LDL is actually LP little a, then there's some implications with that with respect to risk. Now, what you do about that is, it's tough because there's no medicine right now. There are a couple of drugs in studies right now that actually have been shown to lower the LP little a significantly. the question will be whether clinically the outcomes are beneficial as well. But so it's an LDL molecule with an ApoA protein wrapped around that LDL molecule, and it's actually and the thing about it, it is very atherogenic and it's very prothrombotic. Okay, so I like to call it increases your risk of forming blockages in these arteries or plaque in the arteries, but also increases the risk of thrombosis or clotting in the arteries. So a lot of heart attacks are not because you have a 90% blockage. Most heart attacks are on mild to moderate blockages of 30 to 40% stenosis or blockage in the artery. But it's that plaque rupture, and then the clot forms. Okay, that thrombosis occurs in the vessel, and now you have 100% blockage in that artery because of the clot formation.
Got it.
Well, Lp(a) increases this risk of clot formation in the artery. So obviously increasing the risk of heart attack.
And as of now, there's a few things I've heard that can potentially help. What are the drugs that you're referencing?
So these are actually drugs that actually lower the Lp(a) levels, and they actually have not. They're in phase 2 and 3 trials right now. I have a couple of clients that are in the trials, and they have significantly lowered So, for example, the normal level of an Lp(a), I think for one of the main labs like Quest is 75 milligrams per deciliter or something like that, I think, or maybe I've forgotten the units. And we have people who have extremely high levels, 200, 300, 400. And those people are at higher risk. And I've seen those numbers of 300 come down to 20 or 30 in a matter of 3 or 4 weeks.
Wow.
In people that are on the trial. Now, obviously, it's a blinded trial, but obviously they got the medicine because it came down significantly. So I think the thing with all of these drugs, though, we have to wait to see. First of all, are there any side effects from the drugs? And two, does lowering that Lp(a) from 300 to 30 truly decrease the clinical outcomes? That's always the question. We can treat numbers, and I always tell my patients this too, right? I don't believe in treating numbers. You treat the patient. And so I always have to put things in clinical perspective with respect to when I look at a number. But that number has come down significantly, and we'd hope that decreases the risk of heart attack. But the longer term studies would have to be done to kind of show that.
Yeah. It's kind of like, and correct me if I'm wrong, but in the brain space where they were able to remove a lot of the beta amyloid plaque, but the outcomes weren't clinically better. So
exactly.
That's a really good question. Let me ask you a few questions about other ways that people think that they can lower Lp(a) potentially. What about niacin?
Niacin has been shown to lower it, and I think a few studies I saw somewhere in the 15 to 20% range. Okay. In clinical practice, I have not really seen that. Okay. The other big thing that was out there is a cardiologist who wrote about this a lot. Jim Roberts wrote about vitamin C.
Interesting.
And high dose of vitamin C lowering the Lp(a). I've seen it work in a select few people, but not everybody. So there's more nuance to lowering Lp(a) than just giving high dose vitamin C. Because I pushed that concept to the max when I was reading all of his work. I was like, okay, let's just give these people high dose vitamin C, and I was giving IV vitamin C as well sometimes, and still we didn't see any significant drop in the Lp(a). The PCSK9 inhibitors do lower the Lp(a), probably 30% or so. I think the numbers are actually 30 to 40%. So you can lower them with it. And I think that's the only drug really out there right now the drug class that I know that we can see some routine lowering of the Lp(a).
Okay, so Lp(a) obviously highly concerning. We want to keep that lower, but there doesn't seem to be that much that we can do about that number.
Right.
What about the other numbers that we can look at? And if you're listening to this podcast and you are trying to get a more in-depth cardiac panel from your doctor, do you recommend asking for an NMR? What do you recommend asking for?
Yeah. So the NMR is actually looking at this kind of the sizes of the particles. So we talked about the small particles and the small dense LDL particles being more atherogenic. Also, it allows us to look at HDL. So one of the other things that we've been taught is that HDL is the good cholesterol, right? And the fact of the matter is, not all HDL is good cholesterol. Not all LDL is bad cholesterol. So by looking at the particle fractionation of HDL, right, we can actually look at those fractions of HDL that actually are beneficial. The larger HDL particles are more beneficial. And the role of HDL and why we say it's good HDL is responsible for a process called reverse cholesterol transport, right? It takes cholesterol out of tissues. It takes cholesterol out of arteries, if you will, right? And so with large HDL levels being adequate, right, then we're going to have more reverse cholesterol transport in place, and it's going to be acting more effectively. And so those are some of the numbers. So I want to know the large HDL particles. I want to know the small the small LDL numbers. I want to know the ApoB is another one that we've talked about, and we hear a lot talking about. And ApoB is just a measure of the number of LDL particles, right? There's total number. There's one ApoB per LDL molecule. Okay. So it really gives us a number, whereas the LDL itself actually doesn't necessarily give us the number of LDL particles, right? And there's a lot of calculation with some of the numbers with LDL are even calculated. But when we measure ApoB, we are actually getting the number of LDL particles. And so that has been shown to be a predictive risk factor. And trying to get that number, and I'm a little bit different than some of the mainstream with respect to that LDL number, or shooting for a number, because honestly, I just don't like shooting for a number. I'm very individualized with my clients. And I think that when we start to have a number for everything, it could be problematic, right? Does an ApoB of less than 90 mean that I won't have a disease if I have a lot of other risk factors? And we'll go into this a little bit later. I think that there are a lot more residual risk that we're not looking for when we talk about things like oxidative stress caused by environmental toxins. And so we're going to go there, but I feel very strongly that we're missing most of the issue by just kind of chasing a number for cholesterol. All right. Yeah. And so the whole cholesterol business is when that cholesterol is oxidized, and we have all these something called lipid peroxidation products. That's where the issues are. That's what causes vascular disease.
Would that be oxidized LDL?
Yes, that's oxidized LDL or some other oxidized lipid oxidation products as well. But oxidized LDL is one of the other markers that we look for in the inflammation panel as well. So that is a marker that 100% oxidized LDL, looking for that. There's some other lipid peroxidation molecules, and I don't mean 4-HNE, malondialdehyde. I don't want to go too deep into the science, but
MMA one of them? Am I saying that right?
So MDA.
Oh, MDA.
Yeah, MDA. But you're thinking about methylmalonic acid is for B12.
Okay, interesting. Because I do the longevity panel from Vibrant, and for the first time, in the inflammation category, they're putting this marker. I've never been measuring that before in the past. So
MDA, I think, is in the Vibrant panel. It's the oxidative stress panel.
Okay, so tell us more about that.
Yeah, that's actually, so I'm actually at this Vibrant Longevity Conference tomorrow, and that's what I'm talking about. I'm talking about using the oxidative stress panel to really help you understand the risk for lots of chronic diseases. It's not just cardiovascular disease. It's neurocognitive diseases, it's autoimmune disease, because all of these chronic illnesses are driven by inflammation, and inflammation drives oxidative stress, and vice versa. Oxidative stress drives inflammation. Yeah. So being able to measure oxidative stress markers, like, so some panels in the past, what we've typically looked at in the past are 8-OHDG. That's on a lot of panels that measure oxidative stress, right? But Vibrant has come up with a panel that now has oxidative stress and nitrosative stress. And it's a whole nother topic, but that's a hot topic that I think we've overlooked. And a lot of my work and what I'm going to be talking about is about nitrosative stress, reactive nitrogen species, as opposed to reactive oxygen species. Yeah. But this panel allows us to look at molecules like the MDA, malondialdehyde, 4-HNE, okay, looking at nitrotyrosine, and these are all oxidative stress markers of lipid oxidation, protein oxidation, DNA oxidation, RNA oxidation. And so that's what we're kind of measuring. And so where I'm going with this, with respect to your issue with the cholesterol, and it's not the cholesterol that's the problem. It's changing this cholesterol or these lipid products into an oxidized form that causes more inflammation, that damages the vessel wall, and that's when we have plaque buildup and all that stuff. The problem is, so what we should be focusing on is addressing the things that are oxidizing our cholesterol. The cholesterol, we talk about this all the time, right? God gave us cholesterol for a reason. Yeah. Cholesterol helps to heal the body, right? Cholesterol it's imperative for brain function. Yeah. So if we're always trying to just lower a number, we can continue to lower that number. I don't care if the number is as low as we could possibly get it. If I have all these other things that are going to cause that cholesterol to be oxidized, we're still going to have the same problem.
Got it.
Okay. And so that's why it's important to kind of really address the things that are causing the oxidative stress in our body.
So what I'm gathering, when there are recommendations that are pretty broad out there that LDL should be as low as humanly possible, maybe even at a level of an infant, I've heard. You tell me more. Like, so do you agree with that? You don't?
No, absolutely I don't. Absolutely I don't. Now, I'll tell you a story. I'll tell you a story about patients. And if you look at the data, and we can read, for example, the PCSK9 inhibitors can lower cholesterol tremendously, right? I have people come in with an LDL cholesterol of 20, okay? And what the data will tell us is that there's no cholesterol that's too low, right? And what's said and what we hear, okay? I can't tell you the number of stories of people who are coming in with these cholesterol numbers, that total cholesterol of 90 and LDL of 20 or 25, and they come in and they feel miserable. But more importantly, the most common thing that I see is neurocognitive impairment, dementia. I remember distinctly about 4 or 5 years ago, there was a businessman from Chicago. He ran a marketing company in Chicago, and his wife brought him to me, and he had been all over the world. I mean, he had been all the major institutions. And they were in the process of working him up for dementia, and she was distraught, and he gotten lost in Chicago a couple of times. They had to send the police to find him and all these type of things. I remember he showed up to me, and he was one of those people who had, I don't remember the exact numbers, but his cholesterol was under 100. His LDL was like 25 or 30 or something. And so literally I sat there, okay, and I said, did anybody talk to you about his cholesterol being too low and maybe that contributing to the neurocognitive issues and some of the memory stuff that he's having? No, nobody mentioned anything about it, right? Nobody. So all I did, okay, and this was actually, I think he was on a PCSK9 and rosuvastatin. All I did, honestly, I cut his rosuvastatin in half, okay? I think I went from 40 milligrams to 20 milligrams. And I kid you not, in 2 weeks, I get a call from his wife, and she was crying. She was literally crying, and she was thanking me for giving, this is what she said, thank you for giving me my husband back.
Goodness.
And in 2 weeks, it might have been 2 or 3 weeks, I have this, actually, she did a testimonial. It might be still on my website. But for me, that was and this was early in my transition. This was kind of really early in my transition. For me, that was a wake-up call, too. I was like, I really started to think about, okay, what am I doing? Well, how are we truly getting these people better? And I'm reading all the data saying there's no cholesterol that's too low. There's not, this neurocognitive issues don't happen. Well, I can promise you now, after 7, 8 years of doing this, they absolutely happen. They absolutely happen. And when the cholesterol gets too low is when we start to see these things.
Gosh, it's such a bummer that, this is not more widespread, because my first, comment would be, I mean, the brain is mostly fat and water, right? So it would make sense that you would meet some of that.
Right.
But just obviously I'm not a doctor, but it's just like me, like critically thinking, But then the second part of it is, how did this man, like, what was the process in which he went on both the drugs? And then, they're looking at it saying, okay, it's so low, he has these symptoms, and we're not going to investigate further.
Yeah, I can't remember exactly how he ended up on them, on the combination of drugs, and I don't know how the cholesterol got so low. I just know that he had come from some Stanford, somewhere, one of the places up in New York. There was a major institution. And I mean, I just remember looking at it and just asking that simple question. I can't even remember how he got on so much of it. And I think he probably had some underlying heart disease. And again, we have been it's ingrained in our mind that if I have heart disease, my cholesterol needs to be as low as it can possibly get. And I will say it again, we've missed the forest for the trees. The cholesterol in itself is not what causes the heart disease. Like, man, and we know this now. We know the mechanisms of coronary disease. We know it's inflammation driven, all right? We know that oxidative stress plays a major role. We know that the macrophages forming these foam cells, that happens because of the oxidative stress and the whole inflammation cascade being upregulated. So why are we chasing a cholesterol down when there's so many other things that are causing the oxidative stress and the inflammation in the vessel? Right? That's kind of it's really crystal clear to me now. And it's also crystal clear because as technology evolves, we're able to see these things now with imaging, like clearly imaging, which is a CT angiogram where we can look into the arteries and we can characterize the plaque, meaning looking at calcified plaque and soft plaque versus what we call low density plaque, that more atherogenic, the sticky, if you will, more inflamed plaque. And what I typically see is if there's a lot of vascular inflammation going on the biomarkers, measures like lipoprotein, phospholipase A2, LP, PLA2, something else that should be measured as an inflammatory marker, right? Myeloperoxidase. When we see those numbers elevated, we will oftentimes see this sticky, low-density plaque when we look at the imaging, right? And so my goal when I'm working with my clients is that's high risk plaque, right? So what I'm trying to do is, okay, we have to calm this inflammation down immediately and then kind of get to the underlying root of where, where that's coming from. In those type patients, I absolutely use statins, okay? And I'm not an anti-statin person, but the statin is not being used to lower the cholesterol. The statin is being used for the pleiotropic effects that it has. It's being used for the antiplatelet effect that it has, so the anti-sticky effect that it has. And it's being used for the anti-inflammatory effect that it has. Because I see vascular inflammation there, right? This is a high-risk patient. So I use the statin, and I just about telling patients, we need to use a Band-Aid right now, okay, until we can get to the underlying root cause of why I have all this vascular inflammation, which oftentimes goes right back to the lead, the mercury, the insecticides, the pesticides, the PFAS, all that stuff that we can talk about. But unless you go looking for the reason why they have this vascular inflammation, we're just continuously chasing cholesterol. And why do we think that heart disease has been the number one killer forever?
Yeah.
But we keep chasing the wrong things. And I'm not saying just let your cholesterol go crazy, right? I'm not saying, what I'm saying is we have to start to look at what's causing the change in this cholesterol to a format that's problematic.
Yeah. Wow. I mean, this is profound, truly. Like, you just don't hear this every day. So I'm excited to dig deeper. Really quick before we go on what other factors are that are causing all this inflammation, I want to go back really quick to fish oil. So there are a few cardiologists that I follow online that have very boldly said that fish oil does nothing for heart health. But you mentioned including fish oil.
Yeah.
Can you tell us more about
So
that?
absolutely. I mean, I think that one thing I will say is that we have to take, everything has this Goldilocks phenomenon, okay? Meaning that certainly if we have too much fish oil, I mean, you can take too much fish oil, right? Fish oil certainly, I mean, there are tons of benefits and tons of studies that show the benefits with triglyceride lowering with fish oil, with neurocognitive health in fish oil. So there are clearly benefits with fish oil. There's a study that came out not too long ago about fish oil having an increased risk of atrial fibrillation associated with it. And I did not actually dive deep into that study to look at the amount of fish oil or anything of that nature. But what I do know is this, okay? When we take too much fish oil, okay, there's separate pathways. There's omega-3 pathway and an omega-6 pathway and how these fatty acids are broken down, right? And they use some of the same enzymes, fatty acid desaturases and elongases. And if we give too much fish oil, we can start to use a lot of these enzymes up. And so the whole omega-6 side of this, of the fatty acid metabolism gets affected there. And so I'm going to change gears to just the whole omega-6 thing where we all been taught that omega-6s are bad, okay? And one of the things that the adulterated, heating your foods with omega-6s, yes, that's bad. That's bad. But we need those polyunsaturated fatty acids. We need omega-6s for lots of different roles as well. I mean, so omega-6s are metabolized into some anti-inflammatory components. DGLA, for example, digamma-homolinoleic acid. That's anti-inflammatory. It comes from linoleic acid, which is an omega-6. So guess what? If my omega-6 levels are too low, right, then we can have issues with some of the anti-inflammatory components of it. So it's nothing is all bad or all good. And it also has to, you have to take in consideration, if it's, again, some type of process adulterated omega-6, that's different than getting a true, clean sunflower product or something of that nature. And I really only over the last year or two started to realize this. I was one of the ones talking about omega-6s are bad just like everybody else until I started to do some research. And I started to work with a lady named Patricia Kane. Patricia Kane is a person who really is a cell membrane. She actually is a person who did a lot of the work with phospholipid therapy, something called lipid membrane replacement, how we can improve cell membrane function by giving your body back phospholipids, phosphatidylcholine, phosphatidylethanolamine, to help that cell membrane be more efficient. Going all over the place here, but I say all that to just say it's important that, back to your fish oil question, I think that certainly you can use too much fish oil because then we start to use up those enzymes that are important in metabolism of the omega-6s as well. But clearly, and I see in my patients daily, that we can do lower things like the triglyceride level, improves insulin resistance. So I think there's a role, but we have to be careful in how much we give it.
All right. Do you have any, general recommendation? Of course, depending on where your omega levels are right now, where you're starting from, that can vary.
Yeah.
But do you have like a safe recommendation? And maybe, I don't want to put you on the spot with a brand, but the other concern with fish oil, right, is having it being oxidized.
I think one of the things that I do, I think it's important to test, not guess. I'm sure you've heard lots of people say that. So when we say 1 gram, 2 gram, 4 grams of fish oil, what's right? There's so many nuances to what's right for each individual. So I actually measure the omega-3 concentrations. I use organic acids testing from Genova, and that's going to give me my fatty acid panel, and I get to look at kind of where they are with their EPA, DHA. And so where that number normally lies, somewhere from 1 to 2 grams, maybe sometimes a little bit more, but most people, I'm just doing 1 to 2 grams of fish oil based on their markers.
Okay. Yeah, that's super helpful.
As far as a brand, I actually, and I don't know, I stick with one brand. I use Biotics Research, and it's called Biomega 1000. The reason I use it is it's a very high potency. It's a total of just over a gram of EPA and DHA per capsule. So it's a fairly high dose omega-3, but also the price point. Omegas, if you get a high potency omega, it can be somewhat pricey for patients. Their price point it's really good, and it comes from a company that I trust with respect to the sourcing of their product and stuff like that, and not hopefully having a lot of mercury and dioxins and PCBs and stuff like that.
Yeah. I take Metagenics.
Yep.
Metagenics. How do you?
Yep. I actually like Metagenics as well. Metagenics is another great company. They have a great product as well. There's a few of them. Zymogen has a great Omega Pure product as well. So there are a few out there. There are a few of these companies: Metagenics, Zymogen, Biotics Research, Designs for Health has a good one as well. So I think that if we stick with those brands, I think that you're going to be pretty good. What I would strongly recommend you don't do is one of the brands from Walmart or your local CVS. You don't really know what you're getting.
Yeah.
And the reality is, the mercury toxicity, dioxins, it's a real issue. And I think it's becoming more of an issue with these products as well.
Yeah. What are your thoughts on SPMs?
Oh, man. Great question. So, man, I have a great story about that. But this is, so SPMs are pro-resolving mediators. I think that they are really something that we've missed with respect to a whole anti-inflammatory spectrum of how we can address inflammation in the body. I tell my patients SPMs are my natural steroids, is what I call them.
I love that.
So when people have lots of inflammatory type conditions, and if it's particularly joint pain, aches, things like that, I use a lot of SPM products. Metagenics has SPM Active, I think.
Yeah.
And then Designs for Health has SPM Supreme, and I kind of go between those two. I don't think I have a favorite right now. But just understanding and these are all just kind of downstream metabolites of the fish oil that actually have tremendous anti-inflammatory properties. I also think, let's go back to the genetic question, because one of the things that just happened just a couple days ago, because when you do a lot of genetic testing, in order to get down to those pro-resolving mediators, there are specific genes that take you there. And I mentioned a few of them just a second ago, things like the FADS, fatty acid desaturases, and the elongases. If you have gene variants in those specific genes, then you can't take those omega-3s down to the pro-resolving mediators. So now you are at a much higher chance of having all this inflammatory stuff going on. And I had a patient just the other day that's what was going on. And so I'm interested to see what happens. This was literally like, maybe yesterday, day before yesterday, but I'm interested to see. I put him on SPM Supreme, and I'm interested to see if all these inflammatory things get better just based on knowing that he can't convert the omega-3s down to these pro-resolving mediators. So I think that when it comes to inflammation and dealing with a lot of those, the SPMs are not many people know about pro-resolving mediators. So something that definitely we should be using more of.
Yeah, I love that. And tell us again one more time, what is the gene SNP that would?
So FADS, fatty acid desaturase. Okay, and then there's another one called elongases. Is ELOVL1, ELOVL2.
Nice. Okay, great. Now let's get into this inflammation and why it's going on. You've mentioned it a couple times. There's something that we obviously relate on so, intensely is this toxic burden, right? So I've been measuring a total toxic burden, the one from Vibram, which combines the 3 tests together. And I've been putting it out there for many, many years. And I've just been talking about this for a long time. So I'm so excited that this is a big part of your practice too. So tell us how you kind of came to understand that toxins had such a big role, and how are you incorporating that into your practice, and what can people do to reduce toxins?
Yeah. So let me tell the story about how I realized toxins were so important, because it's a pretty impactful story, and honestly, it's unfortunate what happened with this. But so I'm not sure, I'm a cardiologist, but somehow I got to be known as the person who takes care of ALS patients.
Interesting.
And the reason is because I just dive deep into everything trying to figure it out, right? And so I was in a couple of groups where I had been working with some ALS patients, and well, obviously we know that ALS is a disease. We don't really know what causes ALS. There's no one thing that causes ALS, so to speak, and there's no real treatment per se for ALS as well. But I was working with ALS patients, and I was on a webinar one day, and somebody came on doing a webinar with this test out of Germany. Okay, and the name of the company was IGL. Okay, and IGL was a company that actually it was a company that measured toxins, but not only did they measure toxins, they measured toxins that were bound to specific gene loci. Okay, meaning that they would tell you a chromosomal locus where a specific toxin was bound. Okay. The test also allowed you to measure mitochondrial function, right? We got to see the number of mitochondria. We got to see mitochondrial membrane potential. We got to see cardiolipin, which is an important fatty acid on the inner mitochondrial membrane. We got to see NAD, NADH ratios and glutathione reduced and oxidized ratios. It was a test like I had never seen before. When I saw the webinar, and I thought to myself, if this test is doing everything it says it's doing right now, it's going to change the world. Okay. And so, about 4 or 5 months went by, and I didn't order the test on anybody. It was a fairly expensive test. But one of these ALS patients, I was trying to work with them, trying to understand. We know that, most of these diseases are mitochondrial diseases. And I knew that, toxins have a lot to do with the neurocognitive diseases, Parkinson's, Alzheimer's. And so I knew of this test, and I said, maybe I'll just order this test once and let me see if it does what it says it does, right? So I talked to the patient, and he agreed to do the test, and we sent it off to Germany, and this test came back. So the test came back, and some of the things that it showed is that the phosphatidylcholine, phosphatidylethanolamine, which are important parts of cell membrane, were low. Anticardiolipin was impacted and low. The number of mitochondria were low. Tons and tons and tons and tons of toxins, and specifically he had formaldehyde bound to a gene locus. Okay, I don't even remember, it was 3p21.1, something like that. What the heck is 3p21.1, right? This is kind of me thinking of, it's telling me the chromosome. All I remember from medical school is, okay, that's the chromosome, and P means a short arm. I don't know what the rest of this stuff is. So fortunately, the beauty of the internet and Chat GPT and all this, I don't know if there wasn't even chat, it was just the internet at that point, because I don't think I was using, this was 2021, 2, something like that. Anyways, long story short, I'm trying to figure out, okay, what genes are located on chromosome 3p at 3p21.1. Okay.
Mm-hmm.
So I'm looking, kind of going through all the data, pulling papers, and I find that there is a gene there. It's called the human metabotropic glutamate receptor 2 that's located right where the formaldehyde is bound. Well, the one thing I already knew about ALS is it really has to do with glutamate upregulation, and glutamate, I mean, has a lot to do with ALS. So at this point, I'm thinking to myself, maybe this is just coincidental. I don't know. Maybe this is coincidental. And so then at this point, I'm thinking to myself, this is kind of crazy, but okay. So then my attorney, his mom has Parkinson's disease. Okay.
Mm-hmm.
And well, it's a pretty cool test. You want to try this test? We just send it back to Germany, and it comes back again for Parkinson's disease. And what I see on this test was same type things. All the mitochondrial numbers are low. The mitochondrial membrane potential is low. I mean, and this was kind of cool because you can actually, we talk about it being a mitochondrial disease, but to be able to see it, right, measure it, I'm like, oh, this is pretty cool. But she ended up having chlorotoluene bound to a gene, and I don't remember the exact locus again. So I just have to go figure it out what it is. I'm going to all the literature. I'm pulling all these articles. And I kid you not, the chlorotoluene was bound to the a loci where tyrosine hydroxylase. So tyrosine, we know about Parkinson's and dopamine, right? But tyrosine is converted to dopamine, and it uses an enzyme called tyrosine hydroxylase. Well, guess where tyrosine hydroxylase was? Right where the toxin was bound, okay? So at this point, it's now 2 people, right?
Yeah.
I have about 15 of these cases.
Wow.
That I figured out stuff, and it's literally, your mouth falls to the floor, okay?
I am so excited over here. I'm like, yes.
So that was my kind of aha moments that, man, these toxins are real. Like, we've been talking about toxins. We still talk about toxins. We talk about them all the time and the problems that they cause or whatever.
Yeah.
But to see it, okay, and to see... So back to the first guy with ALS. There are procedures and how we can get these toxins out, how we wash these toxins out using fatty acids, using lipid membrane replacement therapy, how we wash these toxins out. We got before and after showing that we got rid of the DNA adducts. That concept of a toxin being bound to DNA is called a DNA adduct. Right?
Yeah, this I don't quite understand. How to explain this?
So the toxins are bound to the actual DNA, right? And we've heard about the concept of epigenetics, right?
Mm-hmm.
So when we talk about epigenetics, that's all we're talking about. We're talking about how, whether it's a nutrient, whether it's a toxin, how that toxin affected the gene expression, upregulating or downregulating that gene expression. Well, we now know that, I mean, this is pure evidence that there is some epigenetic component because I got a toxin bound to a specific gene, right?
Yeah.
And so how do we get it out? And this is all came through work of who I was just talking about, Patricia Kane's work and lipid membrane replacement stuff and using phospholipid therapy to actually clean these cell membranes and to clean these toxins out. Mm-hmm. And so, and we have between Patricia and other practitioners, Bruce Hoffman up in Canada, there are thousands of people who we've seen these DNA adducts and then clean the DNA adducts away with phospholipid therapy and using some, and it's more than just that, but there's some other things, that butyrate and things like that. But we did this with this guy, and he went back to his ALS doctor, and his scores, his strength, I mean, his numbers, when there's something called, I've forgotten what the actual, it measures strength in kind of all different parts of the body and stuff like that. And his score increased by something like 50 or 75 points, which was pretty significant.
Yeah.
Just by doing this process of kind of getting rid of the toxins and getting rid of this DNA adduct, man, he got remarkably better. Okay. So again, in my mind, I'm like, holy cow, this is absolutely crazy. Okay. So that was my kind of I have people I have a lady who had all these lesions on her leg that she had been treated for years and years. And they thought it was, they didn't know what it was. And so she ended up having nicotine bound to a gene that causes an autoimmune skin disease. Okay.
Nice.
And it turns out where the nicotine came from, I had no clue about this. I think about nicotine, I think about smoking. Yeah. Well, nicotine was a primary ingredient in pesticides, right? And she grew up on a farm out in somewhere, and they used to run through the fields sprinkling all the stuff to kill as a pesticide, and all those pesticides had nicotine in it, right? So now again, these stories, I couldn't make this stuff up anymore, and I'm just like, this is incredible. So let me just fast forward. So that just got me interested in all this, all the toxins. Now, here's the interesting thing. The IT for this company and what was going on, I don't know all the details, but I'm just going to tell you what happened. Okay. The guy the founder of the company and all of the IT, the guy died. Okay. And the week that the guy died, the test went away. We haven't seen the test back on the market since. We haven't seen that. That test it literally disappeared from the world.
We need to bring that back.
That test is gone from the world. If anybody wants to look at it, interestingly, I think this was August of 2024. If you go to Mark Hyman has a blog on getting an oil change for his mole disease, right?
Yeah.
If you look up, and it's called Getting an Oil Change or something like that. If you look up that blog, he actually had that test done, and all its samples, it's exactly what I'm talking to you about right now. Now, what he didn't show, he just showed all of the toxins and how they got it out using phospholipid therapy. But with that test comes also toxins that are bound to specific genes, the DNA adducts. But it's a great blog explaining exactly what this test was doing, how it worked, and how you can get rid of these toxins. So I would encourage everybody to look at that. I mean, it's really interesting how that kind of popped up. I saw it up, and there was not a lot of people using this test. I've been back then I was trying to tell people, look, somebody needs to talk about this test. I'm trying to get it in front of the right people so people could, somebody needs to know about this. And right when, right around that time, Mark published this thing, and I was like, I knew somebody had to bring this thing forward. And then the guy died, and then the test is gone. Yeah, so if you can help bring that back, that's phenomenal. I can tell you stories like it's just unbelievable. Anyways, I say all that just to say that's how I got interested in toxins. And I knew that toxins were more of an issue than we ever thought once I saw that. And so really my practice just started to evolve towards, every person that comes in, I don't care if they have whatever, heart disease, absolutely. But I have people with Alzheimer's and Parkinson's and autoimmune diseases. When you look in those places, when you look at the toxins, they are a large driving factor of the oxidative stress and the immune imbalances driven by a lot of the toxins we're exposed to.
Wow. Yeah, I had, my own story with this. During the fires, I've been doing this lab for a long time. During the fires, it was unlike anything I've ever seen. Like, my medical team didn't even believe this was my lab, right? High levels. So normally, I have 0 toxins in the high range on the Vibrant test. I went to having about 25 to 30 toxins in the high range. It was unprecedented. Everything. Dry cleaning chemicals, BPA through the roof, molds, mycotoxins, heavy metals. Because just think about everything that was burning. Homes, businesses, cars.
Right.
And you can see my house. Like the air quality, I measured the air quality in every single room in this house.
Wow.
And we have 8 Jaspers, the highest level of MERV filtration. We're getting an ERV, the whole home dehumidification, all that stuff. And so I was doing the same thing in LA. So if that happened to me, imagine what had occurred to everyone else, right? But good thing is our bodies do detox. My levels are now back in a good range. But it's interesting because, so with that correlation for the first time, and now I'm actually thinking, I think the number that I'm talking about is MPO. That's the number on the Vibrant test. Does that sound right?
Myeloperoxidase?
I think so. Is it in the inflammation panel and the longevity?
Yes.
Okay.
Yes.
So for the first time, when those toxins went up, I saw that number increase.
Myeloperoxidase went up.
Does that make sense?
Yeah. Yep. That's a neutrophil. Myeloperoxidase enzymes up when neutrophils are super active. So with respect to inflammation, yeah.
Got it.
Yeah.
But what was interesting is that my HSCRP never actually went up. So is that like an earlier marker then?
Well, yeah, no, it's interesting. I don't know. I always go back to the genetics has a big role in everything. And I know I used to people just say that, and mainstream medicine would just say that. But when you measure genes, you really can see that some people just typically have a higher or lower CRP. There are genes that actually control that. When we look at thyroid hormone, I'm just kind of giving TSH. There's sometimes it's just a genetic thing, right?
Yeah.
And so it may be, you would think if I have inflammation and systemic inflammation, I would expect your CRP to be elevated. I would expect some of the other inflammatory markers to be elevated. Looking at cytokines like TNF alpha and IL-6. But, one of the things I've learned is there's not a perfect correlation in any of these things. So what it also tells me, there's a lot more nuance that we don't really understand because
So much nuance.
Yeah.
So much nuance. Okay, so I want to go back to toxins. What are a couple of recommendations just that you might be able to give for someone that can't necessarily afford this test? But then also let's talk about this phospholipid therapy.
Yeah. So first and foremost, the test is an amazing test, and anybody that can afford it, I would strongly suggest you guys look at the Vibrant Total Tox test, and Total Tox plus PFAS now, because they've added in the perfluoroalkyl substances now. Because when we talk about just overall health and anybody who's looking for longevity, I'm also a firm believer right now when we talk about what makes us sick and what makes us get old. We've talked about this and I've said oxidative stress 100 times now, okay? But what drives all of that is largely the stuff that we're exposed to. It's a lifestyle and the toxins that we're exposed to. What I've learned using this Vibrant test is that there are very, very few people who don't have any of these toxins that are elevated to a certain extent. And the people, interestingly, that typically have the least amount of these toxins are people who have been using an infrared sauna. Okay, so I have a couple of my friends that have been using infrared sauna for years. And, everybody gets the toxin test when they come in my office as well. And then for the first time I see a toxin test that absolutely nothing was elevated. And I was like, well, geez, that's proof of principle about the infrared sauna. So one of the things that I would tell you, if you can't get the test, then everybody, I mean, we can see all these biohacking technology, hyperbaric chambers and lymphatic drainage and photobiomelight beds. I'll tell you, the number one tool I feel from a longevity perspective is a sauna, okay, for so many reasons.
Yeah.
The toxins being probably the top reason, but there's so many other things that infrared sauna does. So using infrared sauna as much as you can, or using sauna, I don't know, there's some debate about it. Does it have to be infrared or not? I think that as time goes on, we'll learn more about the differences. I don't know that we've seen significant head-to-head comparisons, but we know that sauna in general, all of the finished studies that Rhonda Patrick talks about, shows the benefits of the sauna. I do think that, some of the benefits with infrared maybe have more mitochondrial impact. I don't know that for sure, but just in theory. So using a sauna to help detoxify is that's my number one biohack, right?
Yeah.
It really is.
That's the exact same thing I recommend. And actually, I don't even think I got to share this with you, but we actually own a sauna company now. So I went looking for the cleanest sauna. So I can self-report that my toxin, as you're saying, most people, and we saw this, when I was running my clinic too, that everybody came in. Everybody thought they were going to have a low toxic burden. Everybody came in with a high toxic burden. So I can show you toxin tests that are so low. And that was correlated with everything else I do, right? Healthy lifestyle, sleep and diet and exercise, all that stuff. But I've been doing sauna for so long, right? And so infrared sauna.
Yep.
And so I went to go look for the cleanest sauna, because then I understood that there's these sauna companies, specifically infrared sauna companies, that are using wood glues, plywoods, polyurethane. And so then that off gases into the chamber.
Yep. Absolutely.
So I found this company, Heavenly Heat. It was started over 30 years ago for people with chemical sensitivities. That's what the saunas were built for. So the lowest VOCs, we have to get you one, on the market. There's also built-in Faraday cages to shield the EMFs.
Wow.
So 0 EMF, 0 VOC. Long story short, I just wanted a sauna. Now we own the company and my husband is running it. And it's amazing. But the saunas are literally the best. And I totally agree with you. As someone who has multiple hundreds of thousands of dollars of equipment in my house, I'll give you a little tour after we're done. Sauna is the number one thing I recommend.
Absolutely. I mean, hands down, no question. I mean, I use sauna every day.
Yeah, I love it. Same.
Yeah.
Okay, great. So sauna is definitely, and we know the cardiac health benefits, right?
Absolutely.
Huge, massive.
Yep.
So let's go back to this phospholipid therapy. So how do you define that, and what does that, because I love taking the PC by Body Bio. And you know what? When we were at the last event, we were talking about Plaque X IV too.
Yep.
So what does this consist of?
So exactly. So phospholipid therapy is the PC that you're taking from Body Bio. And that was the company that Patricia Kane actually founded years ago. So there is, and so phosphatidylcholine is the primary fatty acid in your cell membrane. There are other fatty acids that are important as well: phosphatidylethanolamine, phosphatidylserine, phosphatidylinositol, cardiolipin. But phosphatidylcholine is the fatty acid that really makes the cell membrane very fluid. So when we talk about, whether there, any molecules going in and out of the cell membrane is really what controls all of that stuff. Okay. And then at the end of the day, I truly believe that cell membrane health is the key to our health, period, right? And so as we get older, the amount of phosphatidylcholine in the cell membrane, the bilipid cell membrane, gets lower and lower. The As we get older, the amount of the phospholipids are more oxidized, or toxins are bound to the cells. And so using phospholipid therapy, and you can do it orally, and in taking the right amounts of phospholipid, I will tell you, because I still do some work with Dr. Kane. The dosing of the phospholipid therapy that we typically recommend, and then what's on the actual recommended dose, is a lot less than probably needs to be taken orally to get the phospholipids to the level that they need to be from a cell membrane perspective. I can tell you that I typically, based on some of her recommendations, I'm giving probably 3 to 4 times the doses of the phospholipid therapy that is standard. So what we're trying to do is just improve the cell membrane function, by getting that phosphatidylcholine back in there. And again, and the mechanism by which the phosphatidylcholine kind of helps to wash out these toxins. I mean, I'm not sure of the exact mechanism, but I can tell you, based on that IGL test that I was talking about, using that phospholipid therapy, we were able to get rid of multiple toxins. The toxin panels were just like night and day improved when we look at the before and after giving 20 of these IV therapies. Now, we typically give IV therapy and oral therapy with respect to phospholipids.
So when you're saying IV therapy, are you talking about
IV
like the
phospholipid.
plaque?
So PlaqueX is one form of IV therapy. I actually use a product from a pharmacy in Switzerland called Essential. That was one of the first phospholipid therapies that are out there. And there's some debate about whether PlaqueX and Essential are interchangeable. Okay, this is what I'm going to say about that. Dr. Kane would say absolutely not. There's some issues with PlaqueX. There are lots of doctors that are using the PlaqueX in the United States and in Canada that have had great results with PlaqueX as well. And PlaqueX is just IV. It's just a branded phosphatidylcholine.
Yeah.
Okay. One of the reasons I have been using PlaqueX long before, because they call it PlaqueX because it has been shown to improve atherosclerosis, improve plaque buildup in the arteries. And the mechanism of that is what we referred to earlier. It upregulates the HDL function. It upregulates reverse cholesterol transport. So it basically acts through an enzyme called lecithin cholesterol acyltransferase, and actually helps to pull cholesterol out of the body. Now, there are no big human studies, at least U.S. human studies. I saw a few things in some of the European data. There's a lot of animal data on plaque regression and atherosclerotic buildup, rabbit, mouse data. But I can tell you that I use it in my practice because of some of the evidence that was out there. But I can tell you that I've seen plaque regression measurable. Okay, and in a lot of talks I do, I'll show some of this data with that clearly imaging that I spoke to you about. Right, we can actually measure plaque volume. Right,
Yeah.
and I can show you over the course of a year, by doing the things that we've talked about, getting rid of the toxins, right? First, I saw the toxins, lead and a whole bunch of other stuff, getting rid of the toxins, using phospholipid therapy, and healing the vessel wall. And what does that mean? That means improving the glycocalyx, the inner lining of our vessels. So for me, it's thinking about all the things that are going on to cause this vascular disease to happen, right? And then stacking these things in a way that we could potentially cause some plaque regression. And for the first time, I mean, I was amazed myself, because I think nobody's really kind of put all these pieces. But as I'm thinking through it, I'm like, okay, we got to we got to heal the vessel wall, we got to get the toxins out, and we got to help the cell membrane be normal again, right? And so in doing all those things, we had a 25% plaque regression over the course of a year. Okay, utilizing that type of strategy. Okay.
I love that. So for healing the vessel walls, are you using something like Arterisol? Do you like Arterisol?
Yeah, so Arterisol was the first to the market with this whole glycocalyx product. Okay, I'm the chief cardiologist for a company called Human, and Human has their own brand of a glycocalyx product. They have a seaweed based product. It's called Glynocalyx, GLYNO, Glynocalyx. And actually, it uses a seaweed product called Fucus vesiculosus. And that seaweed product basically supplies all of the polysaccharides that the glycocalyx needs. So it helps the glycocalyx reform on the inner lining of the vessel. And so that inner lining of the vessel is protected by the glycocalyx. A very, very important topic for us to talk about when it comes to healing an artery, right? If you don't have a glycocalyx that's intact, then we don't produce nitric oxide normally, higher risk of clotting and things like that. So the risk of vascular disease is much higher when that glycocalyx is damaged. Okay. And what kind of things damage it? All the toxins. We learned a lot more about glycocalyx with COVID because spike protein totally comes in and obliterates that layer that protects the endothelium. So now, one of the things that I saw in my practice is that when COVID hit, we had lots of people who had uncontrolled hypertension. And I'm sure the listeners, they know people who had just uncontrolled hypertension on 3 or 4 blood pressure medicines and never had been on blood pressure medicines before. And that's largely driven by the fact that the glycocalyx was impaired with the spike protein. And now, all of a sudden, nitric oxide is not being produced normally. The vascular compliance is impaired. And so blood pressure goes up. I mean, I can't tell you the number of people who were on 3 or 4 blood pressure medicines that once they came in, right? I had a device that we measure vascular compliance, a digital pulse analysis. That we can put your finger in the device and it measures the elasticity of the artery. And I got that back in 2021 because I realized that truly COVID was a vascular disease, okay? And I wanted to be able to assess the vascular compliance and microcirculation, okay, right? And what we saw was that that those people who came in, their vessels were incredibly stiff. And then when we gave them back products that actually helped the glycocalyx grow back, right? That we can actually see, one, clinically, their blood pressures came in and we got them off of the medications, at least most of the medications. Right. And 2, the digital pulse analysis, the numbers were much better.
Amazing. I was going to ask, how do we measure this? And so you need this specialized device, right?
Yeah, so there are a couple out there. I mean, there's a device that they call Max Pulse. I have another device called Minla, but they all kind of measure. There are a few of them out there. They're just measuring the pulse wave velocity is what they're measuring. So it's actually looking at the pulse waveform and then taking the second derivative of that and actually calculating the compliance of the artery.
I think that's what Aura Ring is looking at to give you your cardiovascular age. Have you looked at that at all?
It probably is, and I actually haven't. My Aura Ring battery died, and so I have not replaced it. But that's something that's fairly new on there, right?
Oh, here we go. PWV.
Pulse rate velocity. Wow.
Wow. So that's what Aura's doing right now. I'm going to have this other device that I'll show you at the end. It's called Connect. It's that blood pressure cuff. Oh, actually.
That's actually pretty cool that they're measuring pulse wave velocity. I didn't, that must be, how new is that? That's really new.
Yeah, probably in the last 6 months or so.
Wow. I'm going to have to get my ring
But it's
fixed.
pretty amazing because, I do all these tests, right? So I took my cardiovascular age. It was -6.5. Incorporated VO2 max training and I got it down to -11.5.
Wow.
And then when I moved, I kind of didn't have my AI bike and stuff. So it crept back up. Now it's at -8.5, but I'm taking it down at about the rate. I mean, keep in mind, all my other factors are very good. Everything's dialed in, right? But I increased my running and I increased my VO2 max training. And now it's dropping at about 0.5 years per week and a half or so.
Wow.
But this one's an interesting one too, if you've ever seen. This is this new thing called the Connect app. So this has, it's like a blood pressure cuff. So take a peek at that. Look at this. One of the measurements is for arterial stiffness. I'm curious if you think.
So that arterial stiffness is it's a surrogate for pulse wave velocity. So it's the same thing.
Yeah.
So you should see, what you want to see with these two different devices is there has to be some type of, the trend should be the same.
Got it.
Because it's the same thing.
It's so interesting because they say I'm actually out of range because it's like -1, I think. But that should be less arterial stiffness because they say the lower the better, I think.
So SEVR is systemic vascular resistance. You'll have to show me this device actually. And it's just like a blood pressure cuff?
Yeah, just a cuff. It's pretty cool, yeah.
Very interesting, yeah. Yeah. This is like the kind of thing that I'm talking about with respect to being objective about all of the technologies that we have, right? We have so many things at our disposal we're talking about. Being able to have these type of parameters that we can measure, it actually starts to bring a lot more credence to kind of what we're doing, particularly if it's repeatable.
Yeah.
And so, and I always talk to my patients. I'm always thinking ahead on what I can do to prove this. And I think this is just about me taking this step out of traditional medicine. I'm always out to prove. So when somebody questions me, there's no question. Here it is, right?
Yeah.
And so I'm always thinking about technologies that allow me to do that too, with respect to proving it. So that would actually be helpful in kind of a lot of the stuff that we do, looking at, when we look at all this kind of pulse wave velocity, and this is talking about your endothelial health and nitric oxide production. And so how does the photobiomodulation, the red light therapy, and how does hyperbaric, we tout that these things improve nitric oxide function, right? So being able to follow all these parameters and consistently showing that that's what's happening, that's going to be incredible. As we kind of, this journey about health and longevity, it takes all of the, like, these people are crazy out of it, right? Because here it is,
Yeah.
right?
Yeah. I mean, totally. I just made a post and it's showing my, metabolic health based on my within body composition is 25. And, these aren't perfect measurements. I'm very aware. And I also am incredibly aware that this is N of 1. So what works for me, again, based on my genetics, etc., might not work for everybody. But at least it's giving us, what my main goal is to give a little bit more color to women specifically, because not only are we bio-individual, but we're also like different from a man and a woman. And most of the major voices in the space are men. And so I've been excited that, I've gotten a lot of, great press and things like that, notoriety lately, because it's just, there are differences, men and women, but then really drilling down, I'm always trying to really be specific in, this is what my protocol is because of my labs, my health, my supplements, my medical team. So how can I show you what I'm doing and why I'm doing that? So you can figure it out for yourself.
Absolutely. I mean, that's because I think that everybody needs to, we can give some guidance. I think you give guidance and ideas, but each individual needs to realize that, okay, it may not exactly be the same, but at least you have to be able to start somewhere to have ideas on kind of what to do. But the technology that allows you to measure, body composition stuff, and looking at, one of the things that I just started using more of that was kind of just another marker on the page was in the InBody, using the phase angle and understanding the importance of the phase angle as really a surrogate marker of cellular health. On this journey for me of optimizing cellular health, and how do we assess that? I realized that right in front of me on the InBody was phase angle that helps me understand kind of cellular health and oxidation reductive kind of component, which I really wasn't looking at it from that perspective. So we can kind of use that. If the phase angle gets better, then the cellular health is getting better, right? So that's what I'm trying to show my clients as well. And so it's just using all of the technology and the things that are out there that allow us to kind of figure out what's right for me.
Are you testing, so now that this amazing test has gone away, what are you using to look at mitochondrial health, if anything?
It's a tough one right now. I really don't. I know there are tests out there, Mito Swab and some other, and I haven't really jumped into any of those. I'm really just looking at the old surrogate that's been out there forever, is using organic acids. Looking at how the what the mitochondrial function looks like, looking at metabolic products like subric acid and adipic acid, and it's not probably the best. I mean, there are probably definitely other tests out there. I have just not jumped into all of the different mitochondrial tests. If we had things that allowed us to look at mitochondrial membrane potential, and I think there is one out there right now. I just have not really dove into that right now. If somebody does come up with a test that actually is looking at mitochondrial numbers and mitochondrial membrane potential, that's going to be a pretty impactful test, because now, again, we can start to look at all our therapies and see kind of what's moving the needle, right?
Yeah.
So yeah, I don't know. Have you used any of the mitochondrial tests at all?
Not yet, but I really want to. I mean, the only mitochondrial marker that I'm even looking at is, what is it, TGG, on the vibrant total tox burden.
Oh yeah, triglycine, TGG. Yeah.
Yeah.
And I'm not sure. Yeah.
I don't think it's that
Yeah, I
accurate.
saw that too, and I'm not sure I'm not sure how relevant that is either. I see that there all the time, and I read what it is, but I don't think it's very impactful, because it never changes a whole lot, and I don't think it gives you a direction of kind of what you're doing for the patient, but I know exactly what you're
The only time mine changed is when I went from having that high tox burden to dropping it down. I saw a big change. Yeah, it got better. But it didn't make sense, right? The mitochondria had to be super hairy. I mean, they were freaking out, especially I made such a nice environment for them for so long, and they just blasted them.
I'm sure they were like, what is going on?
Yeah, they're like, this is not a hyperbaric chamber. We better get to work.
It's interesting because one of the things when I think about toxins, and this is over the last kind of 6 months or so, I started to realize too, when I think about toxins, I'm always thinking about, I'm thinking about metals, and I'm thinking about the plastics. And the reality is, to your point, particulate matter is the real deal toxins as well that I think that we don't even think about. I have not thought about really what we're breathing in as much until recently. I was just looking at some data on Mexico City and the number of heart attacks and acute heart attacks. And interestingly, when the air quality, there are lots of studies that show when the air quality is at its poorest, the number of acute myocardial infarctions are significantly higher when you start to look at just acute air pollution issues that happen. So I really started to now pay a little more attention to this whole particulate matter thing, and it's real. The air that we're breathing.
Yeah.
So
Yeah, and the air inside is actually typically, they say up to 7 times more polluted than the air outside. So that's why I have a video coming out this week on my long form YouTube about how I make my house as low tox as possible. Like, there's only one rug in here because the rugs actually have VOCs and they can breed molds and bacteria, and just, it's a whole thing we can see on the YouTube video, but it's important. So measuring air quality, inside is a big deal because we spend so much of our life in here.
Yeah.
I have 2 Jasper air filters in my bedroom because you're spending 8 hours in there. And you need to, same thing with my office. I have 2 Jasper air filters. Jaspers in there, and then I also have 2 different monitors. And I mean, obviously, I'm like, I'm over here in my own world, but we're measuring all the things.
I don't know if I want to know all that stuff.
I know it's not for everybody. I'll say that, but okay. So I want to go into exercise and nitric oxide. So how do we measure nitric oxide? How do we improve it? Obviously, we all need to be exercising, but let's remind people of all the benefits for our heart.
Yeah. Well, nitric oxide, measuring it is a little tough clinically, meaning that we don't have great measures of just measuring nitric oxide in the body, so to speak, meaning that nitric oxide, its half-life is very short, but we have surrogate markers of nitric oxide, meaning that nitric oxide actually is a vasodilator, right? So we can look at that. One of the big surrogate markers we just talked about is the vascular compliance. How stiff are my vessels? Because that's what drives the elasticity of the artery is the appropriate amount of nitric oxide. We can also, blood pressure, okay? One of the clinical, measures that we can look at, if somebody has hypertension, then likely the vessels are stiff and the nitric oxide is not being produced normally or being interfered with. And we'll can talk about lots of things and how nitric oxide is made. Maybe we go into that now. Nitric oxide typically is made from arginine. People have heard that nitric oxide comes from arginine, but arginine by itself doesn't make the nitric oxide. There's some other components and cofactors that are really important. And some of those things are, the enzyme that makes nitric oxide is called endothelial nitric oxide synthase, eNOS, right? And that takes the arginine and converts it into nitric oxide, but needs cofactors like tetrahydrobiopterin or BH4 is what that's called. It needs some folate, dihydrofolate to convert it. So when we don't have some of these cofactors, that enzyme can't produce nitric oxide normally. And this is a really important factor and what happens when we don't have the appropriate cofactors, that enzyme becomes what we call uncoupled. Now, all throughout my cardiology career, I couldn't tell you anything about eNOS uncoupling and its role in heart disease, okay? But it's a very important concept because now just the vitamin deficiencies, the tetrahydrobiopterin deficiencies now is going to have a nitric oxide that is not being produced normally. But not only is the nitric oxide not being produced normally, what ends up happening is you produce something called peroxynitrite, okay, which is a very potent oxidative agent. It's a reactive agent. So we've been talking a lot about oxidative stress, and I mentioned nitrative stress. What ends up happening is when you have an uncoupled enos, the little bit of nitric oxide that we do have combines with something called superoxide. Okay. And we've probably heard about superoxide being a very potent oxidative stress, reactive oxygen species. So superoxide combines with nitric oxide, and then we have peroxynitrite. Okay. This is a concept that most people don't even, and I'm saying this because I think there's something that we've tremendously overlooked. Okay. And when we start talking about, and it's going to go all the way back to the toxin issue, because a lot of the toxic issue is mediated through peroxynitrite as well. And so kind of tie this together because I'm going around and along, but nitric oxide, when that enos is uncoupled, can become problematic. All right. So let's go back to exercising. We're going to come back to the whole peroxynitrite thing because I do want to talk about it because I want people to, I've been trying to start this conversation since last A4M, talking about the good and the bad of nitric oxide. Okay, there are different types of nitric oxide enzymes, right? Enos, NOS, and INOS. Okay, overproduction of nitric oxide through INOS is problematic, and we'll get there. So not all nitric oxide has its ugly side, if you will. Okay, so back to the benefits. We know that exercise helps to improve endothelial function, helps to improve nitric oxide release. All right. So it probably is one of the most important molecules out there, not just for vasodilation, but we know it's important in brain function and stem cell release and immune function. And so it's important in delivering oxygen to our tissues, nitric oxide is, right? So we definitely need to make sure that we're doing everything to keep all those cofactors in place. We need to make sure that there's some markers that we have on the same. If you remember, if you've had an advanced lipid test done, you remember a marker called ADMA that's on there, right? So asymmetric dimethylarginine. So asymmetric dimethylarginine interferes with nitric oxide, and it actually causes that enos uncoupling that I just talked about. So that enzyme not working normally. So that's one of the markers that I look for also. So when we're looking at that vascular inflammation panel that we talked about, looking at LP, PLA2, lipoprotein phospholipase A2, and myeloperoxidase, and oxidized LDL. On the Quest panel, in that same section under inflammation, is the ADMA. So that's another really important marker that I use. If I see ADMA is significantly elevated, then I know that nitric oxide production is probably being impaired, right? So then I'm trying to do things that are going to improve nitric oxide release, meaning, more beetroot products, because there's a second way that nitric oxide is formed, and it's through the nitrate-nitrite pathway, which is eating more nitrates and then turning it into nitrites, and then in the gut being turned into nitric oxide. So that's a pathway that doesn't require enzyme, a non-enzymatic pathway that we can make nitric oxide as well. So and those type people, when I see ADMA is elevated, then I'm going to try to make sure we're pushing that secondary pathway to make nitric oxide. With some of the supplements, again, from the company that way back before I was even involved with human, I was actually using a product called Neo 40. Okay. Neo 40 has been around for years. And I remember even when I was just kind of tiptoeing in the integrative space, I mean, the Neo 40 was an incredible blood pressure medication. And so it was helping, tons and tons of people with blood pressure. And then, I guess turn around 5, 6, 7 years later, I'm kind of working with human. And it all really got me started was Neo 40, the product they had, which was actually beetroot and nitrite, and basically utilizing that secondary pathway that we were talking about.
So is just drinking beet juice also helpful?
Yeah, that could be helpful. But the amount of actually of the nitrates that you're getting in the actual beets is probably beet juice is probably not going to be the same. The other thing is always concerned about how much sugar are we getting if you drink. But by the time you drink the amount of beet juice that you need to get, there may be a significant amount of sugar in that to get the beet concentration, or the nitrate concentration, should I say, that we need to truly improve nitric oxide levels.
Yeah. Okay, so potentially some supplementation there.
Yep.
exercise is a
Yep,
great
yep,
one.
yep.
And did you say that hyperbaric
Yeah,
is good
so
for?
let's talk about light beam therapy and hyperbaric. So both photobiomodulation has been shown to improve nitric oxide release as well as the data that hyperbaric oxygen actually improves nitric oxide release as well. So I use the both of those for from a, and I don't, I wouldn't say that I'm using it just for blood pressure. Now, photobiomodulation, I do sometimes when people have significant blood pressure issues. I will use my light bed as part of their treatment regimen from a nitric oxide perspective.
Quick question about the red light. So, obviously, a red light bed is great. Most people don't have them at their homes.
Yep.
I have this little device. It was actually like for joints, but I put it around my neck, like more of a proximal technique. If you were doing red light therapy at home and you potentially want to impact your blood pressure, would you recommend like full body panel or like a little thing?
Yeah, it's tough. I think there, again, the nuances of all of this. I think that this is really tough because when you're in the integrative space, I've seen some things, and I want to show you something when we're done. I've seen some things happen that you can't explain with our normal. It's more of an energetic type thing. And where I'm going with this is with the light therapy, I think it depends a lot on, there may be acupuncture points, heart 7, that can affect blood pressure, and maybe putting my red light right over heart 7 would actually help with blood pressure. So I think that when you start to, and there are probably other factors you could think about of where to use the red light that's going to help the blood pressure. I mean, to help nitric oxide the most, or help with whatever we're looking for. So when you ask that question, I have to step back because some things have happened in the last month or two that really have me thinking about, okay, there's a lot of stuff that we don't really understand when it comes to a lot of the ancient stuff with Chinese medicine and Ayurvedic medicine. I'm gonna show you something that's literally gonna blow your mind, that blew my mind, but it really opened my mind to say, okay, there's something to all of it's definitely something to the Chinese medicine and meridians and acupuncture, because I mean, I have devices that I can use a red light through something. Your audience is going to think I'm crazy, but once I get on a rabbit hole, it's over.
Yeah.
But using sacred geometry, toroidal geometry, and the LED light through that, and I was treating a patient for carpal tunnel syndrome with this little thing. I wish I had brought one, and I'll show you a picture. And there is, bottom line, his carpal tunnel went away, the pain went away. Okay, but more importantly, his lipid panel from April to September, I've never seen anything like this in my life. I've never seen, in my cardiology career, I have not seen, cholesterol went from 250 to 160. ApoB went from like 150 down to 60. The inflammatory markers went all normal. I mean, and we didn't do anything besides, I put this thing for carpal tunnel, and it turns out that this is a meridian, the Chinese meridian for heart 7. And what does it do? It lowers cholesterol, triglycerides. I mean, when I show you this thing that I did, I can't even make it up. I mean, chills. Like, so again, it's one of those things where you start to realize, okay, man, there's a whole lot of stuff out here that we think we know a lot of stuff, but there are some things that when people are talking about these other modalities and ancient medicine and things like that, when you see something like that, like, I mean, I've never in my career seen a change like that. And the guy didn't change his diet at all. In fact, he went to Europe. He was eating everything under the sun. It's
So what shifted it then, you think?
well, I don't know if I really want to talk about this. I debated whether I wanted. I'm going to show you this, but this technology, okay, what it does is it opens the ether to bring the body back into homeostasis, and this is straight from the creator of the device. His words told me. And this guy is a very smart, mad scientist, orthopedic surgeon, and that I befriended. He's like 80 years old. But when I met him, I was like, man, this guy, he knows some stuff. And he sent me this device. He said, I've got it. He called me. He said, I've got it. I'm sending you something. And it was mostly for pain. And then he sent me all of the science behind it. He sent me the books to read on the science behind it. I read the books, and it was all on Tesla's work. on 369 geometry and toroidal geometry. And I said, this is pretty cool stuff. I'm just kind of going about my business until I put that thing on this guy's arm. And when I show you what happened, I can't even, and again, it just opens your eyes to it opens your eyes to a lot of stuff, how we bring, I just started a project, actually, it's interesting. I have a little house that we bought in Anna Maria Island that we're making into a sanctuary, but it's a sanctuary where it's called Prana Sanctuary. And what it is using ancient Ayurvedic medicine with all of these very new technology. So we're actually truly going to blend an ancient Eastern medicine with all of the newest technology that we can find, right? And we're going to bring people in. We're going to have them do a combination of those things. But it's interesting because, I'm a firm believer that kind of things just fall into place. I mean, nothing is by coincidence. Okay, it's just not. And anyways, this guy sent me this thing, and this started to happen, and it really his cholesterol numbers and that whole panel is just like, it's incredible, which made me start to realize, okay, there's some science. I mean, there's some science, and what we don't understand about our universe, if you will, right, and how we tap into. I think you probably do a lot of work with meditation and breath work, and how we kind of tap into us and connect with the universe and grounding, right? That stuff is so important, and nobody ever talks about it. And the things that I see happen, and the things that I've seen in my life, the things my wife and my office, I think I got superpowers. It's not superpowers, right? It's tapping into like what's there for us, right? This is a whole nother subject, but once you start to do it, but once you start to do it, and you can, and tapping into your health. Once you start to kind of do some of those practices, and you start to see what happens, you can say what you want. People can call me, some weird stuff starts to happen.
Yeah.
Okay.
Yeah, I mean, I completely believe. I mean, I'm a huge believer of blending these ancient practices with, I mean, there's obviously something there, right? Like, I mean, it worked for people for so long, and now we've just set this entire new, like, number of standards and how we do everything, the standard, ways, standard protocols. But that's interesting. Well, you'll have to.
I have to show you. I'm going to show you this thing.
Yeah, you have to show me. I'm excited.
I was hesitant to even bring it up, and I was like, I don't know if I want to bring this thing up, because if I bring it, I was actually going to give it to you and show a picture of this thing, but I was like, you know what? I don't know if I want to do that quite yet, because I don't know, that might drum up some stuff that, I mean, I don't know about that right now, but I'm going to show it to you. And so I'm doing a few. So I've used it on quite a few patients now with the pain thing. Pain goes away.
I mean, it's amazing.
It's pretty crazy.
Yeah. Well, I feel like we got to cover a lot today. If there were 3 things that someone should do that's listening to this podcast to improve their cardiovascular health today, what would you recommend?
All right. The first one is what we just talked about. First and foremost, my whole platform these days is, really watching the environmental toxins, and know if you've had those environmental toxin exposures. And if you have, figure out, get with a practitioner, or figure out a way how you can minimize those toxins. Again, the infrared sauna is probably, if I had to start with anything, that's the best way the best thing to do, and for the rest of your life. Okay, I don't care. I mean, nobody is going to be perfect. We're not going to avoid these toxins, and I only suspect that the amount of toxins that are in our environment are going to continue to get more and more and more. So our job is to try to minimize those toxic exposures as much as we can, and be able to get them out, right? The infrared sauna is just a great way to get rid of those toxins. I mean, and some of us have better detox pathways, and we didn't talk about this, but another huge topic is that you and I may be exposed to the same amount of toxins, and you may have much less than I do, because my methylation pathways and glutathione pathways and acetylation pathways are all messed up. Right. And so that in itself, when we're doing those genetic panels, is very helpful to understand, like, where and why do I have all those toxins? Why do we have all these toxins that are built up in this person? And when you see some of the genetic propensities, right, you can start to kind of work around them. Right. If there are glutathione gene issues, we can try to give supplemental glutathione, or if there's methylation gene issues, we can try to supplement with the appropriate nutrients there. So anyway, deal with the toxins, use the infrared sauna, number 1. Number 2, cardiovascular risk assessment, okay? You absolutely have to have an advanced lipid testing with inflammation markers. and the imaging part. So that's the biomarker part. And the imaging part, I mean, I'm strongly a big proponent of using CT angiogram. Now, there's some radiation involved and there's a contrast dye involved. Now, if you're super young and the chances of having vascular disease are really low, I don't know that I would do that right now unless the biomarkers showed extremely high risk. And that's how I kind of make my decisions. Now, if you're older, okay, if you're
May I ask,
sure.
what is super young?
If you are, I mean, that's kind of changing these days because we're seeing heart disease earlier and earlier. But if you're 35-ish, 40, I'm not necessarily saying you jump into the clearly at that point, okay, unless the markers suggest that there's significant heart disease or you have a strong family history. Okay. Because at some point, as you get older, you will probably get those. And so I'm just trying to look at the risk benefit and minimize my radiation exposure and contrast eye exposure if the risk of me having significant coronary disease is low. Okay.
One more question.
Yeah.
What about more people are doing like ultrasound, looking at plaques and ultrasound? Is that a possibility? Or
So a lot of people are doing carotid intimal medial thickness or plaque in the carotid artery. I mean, you can use that as a surrogate marker. It's in no way as sensitive as doing a clearly scan, right? And more importantly, remember I told you that clearly scan allows us to look at the plaque morphology. Is it soft plaque, calcified plaque, or low density plaque? Well, if I just do a carotid ultrasound, I mean, I may see a little bit of a plaque there, but what if I have this low density thrombogenic plaque in my heart artery, right? I can't pick that up and know and really understand the risk from a carotid ultrasound. And I'm not saying we don't do it. I think that it's a inexpensive, non-invasive, and not exposing you to any significant radiation or anything to do it. And maybe at a younger age, 30 to 40, it's worthwhile doing the carotid ultrasound, but it's a far cry from the data you get with the clearly imaging.
if you did it clearly, how often in terms of like what would be safe? Every other year?
Yeah, I mean, I typically will do. It depends. It depends on what I see. I typically say we just have some moderate coronary disease and no significant low density plaque. Then I will maybe do it every couple of years or so. Or I have a lot of my patients that I am doing plaque regression therapies, and so they want to know. And so I may do it once. I may do it once a year just to kind of for the purpose of seeing if we are improving the amount of plaque. But the people who definitely need it, like once a year, or I may even do 6 months, if they have a lot of low density plaque, the high risk plaque, right? I will do it again, probably a year. Probably I would do it again because you want to make sure that you're changing the plaque morphology. If I can change that low density plaque to soft plaque or calcified plaque, I'll take it. If I can get rid of it altogether, I'll take it. But that is the risky plaque. All of the studies show that that's the risky plaque, and I think I'm kind of biased in this because I had a bad experience with one of the first times I did the clearly imaging in this space. What happens is sometimes people come to you and they don't want any medicines. They're anti-medicine, everything, right? They just believe that medicine's all bad.
Yeah.
And I had a person come to me one time, and we got the clearly imaging, and he had just a tremendous amount of this low density plaque with significant coronary disease. And it was a person that, I mean, I recommended that he have a heart catheterization because it was scary looking. I mean, there was a lot of plaque. It was all this thrombogenic stuff. His biomarkers were a mess, but he didn't want a statin. He didn't want to go see a cardiologist. He wanted to have, he was like, I just want to do chelation. It's like, I don't think that's the best thing right now. I'm like, this is actually significant risk here. And again, I think this is what makes my bias with respect to all of this low density plaque. Well, I got a call 3 days later that he died in his sleep.
Goodness gracious.
Right. And so I take very seriously when people have significant amounts of this low density plaque and everything that they've taught us and everything that the studies have shown about low density plaque, it's real. And that's why I say when I see low density plaque, you need a Band-Aid, right? We need to put a Band-Aid on it until we can address all of the regions you have this vascular inflammation.
Yeah, that makes a lot of sense. Was the procedure that you recommended to him, would that just like go in there and clear it out? Is that what that procedure does?
The heart catheterization is actually a procedure where we go in when somebody has a significant blockage and they're having symptoms. We go in through the leg or the arm with a catheter and we inject dye into the arteries of the heart. and we can actually put a stent in that artery to open that artery up. So we put a metal stent there and dilate it open, and that opens up where the blockage is. Now, it doesn't get rid of the it doesn't get rid of that plaque that's there. It doesn't, it doesn't get rid of the low density plaque, and it doesn't address all the other plaque in the arteries. But when somebody has a 90% blockage that has a lot of this low density plaque, that's very high risk to occlude. Okay, very high risk to rupture and have an occlusion in that artery and have a heart attack. Okay, so we can go in and we can put a stent in and we can open up that artery. Okay, now the low density plaque is still in there, but at least the 90% blockages there, there's a better chance now of this not causing a heart attack, particularly when somebody's symptomatic with that degree of disease. So again, and I very rarely recommend that type of thing. I'm really mostly medical. The medical therapy is what I go with most of the time, and it's really addressing all of the issues. But when somebody's having chest pain, chest pressure, chest tightness, okay, you need to take that seriously.
Yeah. I hope in the future they develop like little mini robots to go in and then like
Just going in,
eat up
right?
those little
Just get it all out of there, right? Right. That would be fantastic.
happen.
Yeah, absolutely. With the way technology is moving, where we have some type of nanoparticles that are directed to that area, right? That
Yeah,
can
exactly.
actually somehow
Like cleaned up,
Right.
encapsulate it, and then just excrete it.
Right.
I'm excited for that.
It wouldn't be impossible. I don't think so.
Yeah. How do you think I've seen this new stethoscope that is like AI powered and hopefully it's supposed to be
I
able
haven't seen that. Back in the day, I used to have one of the ones that actually amplified the sounds. But man, oh man, I haven't seen that, but I can only imagine. It's trained in all the different heart sounds to tell. Oh man,
Yeah. So how do you
that's
think?
pretty cool.
I feel like AI is going to be helpful in the medical field in general.
Yeah. I think that no question about it. And I tell everybody this as well. I think that if we don't get with AI and you don't start to utilize it, you will 100% be left behind. I think that there are a lot of people who are fighting it. And from my perspective, I think you 100% have to embrace it, because the way I look at it, for me, it just makes me be, the best version of myself. When you learn how to use it, and half the stuff that I talk about now and helping me understand, there's nothing better in putting pieces together than to have AI by your side. And you do have to check it, but there's nothing better than putting all these pieces when we talk about nuances and how this fits with this and how it fits with this. This is one of the things I think I'm kind of really good at nowadays. When you have all these things out there and trying to pull pieces together, well, how does this relate to that and this relate to that? And you can start to just get ideas on how you start to pull the pieces together. In a million years, I would not be able to do that if I didn't have a technology like AI.
Yeah.
And so with respect to providing care for the patients, all the genetic stuff that I talk about, I will go to AI and I have a program that actually redacts all of the patient information, and I will have it help me understand and putting these pieces together, all these different pieces. And that's when you go back to your patient, now you have literally that whole thing that I told you about with SPMs and FADS and ELOVL. Again, I was trying to understand something that happened with the patient. And I was like, what is this? And so I just asked the question, and lo and behold, it said, go to the gene. I went to the genes, and there it is.
Yeah.
So
it's amazing. It really is amazing. Because I order like every quarter, I'm looking at thousands of biomarkers, right? We're doing tox tests, but we're also doing micronutrient testing and then comparing all this stuff, then a couple hundred other biomarkers and looking at gut biomarkers and trying. It's too much for like one person, and especially to like think about it linearly, like over time, and how did this one thing impact? So, I'm a big fan for sure. I was going to say there's this platform called Open Evidence. Have you heard about that? So it's a medical provider only. And so they have now partnered with, the Mayo Clinic, which I'm super excited about. So, the way I have it in my brain is like they're writing the note, but then if they mention a condition, this open evidence can actually pull in the most up-to-date literature on that condition. So that could be a game changer.
Yeah, that could be a game changer. And having AI being able to, where I see it going also is being able to detect patterns. And we're going to be able to really correlate a lot more things, because AI can get into, if AI can see, just imagine if AI can see my entire EMR and all the different biomarkers and all the clinical conditions that a patient has. And just think if it's doing that with thousands of people, right? When we start to kind of pull all these patterns and correlations together, right? That's where I think it's really going to be, and the ability to do that. I mean, it's pretty easy. I'm working with another company on something like that. Now, how do we pull all this data and start to get data on specific patterns of these biomarkers and things like that? That's where I see another huge potential help in the medical field.
I love that. Okay, I think we got two of the three takeaways. So
Oh yeah,
we had exercise and sauna, then we had the comprehensive
and
diagnostics.
and then
How often? Like once a year, twice a year?
once a year probably.
Okay.
Once a year is probably fine. Just to make sure you're not slipping, off the wagon, so to speak. And then the third thing, this is a hard one for me. I'm going to say this because I think it's hard for all of us, but I think it's so important. And it's going to sound corny, but when it comes to just in general, how we live our lives, heart health, I mean, and maybe this is a very political kind of thing right now. I mean, why don't we live in love? Like, why don't we spend more time? I do what I do and I got out of the system because I truly enjoy helping people. I truly enjoy just me. I don't like to see people suffering. All right. And if I can do anything to help with that and whatever rabbit holes I have to go down. But I think if we all really appreciate each other, there will be a lot less stress in the world right now. And I think that's what drives a lot of this chronic illness. We didn't spend a lot of time talking about that, but I think it's incredibly powerful that the stress that we're all under for whatever the reasons, right? That emotional stress that we feel has actual chemical correlates in our body, and so that I think that really trying to live in love, relax, not let the world get to us is super important for not just heart health, all health. And so I know that kind of came out of nowhere, but I just think in today's day and age, as I try not to look at the news. I try not to even look at that stuff because it just drives me crazy.
Yeah.
But if we all kind of just we don't connect anymore, right? And I think that one of the things we know about the human nature is that when we start to connect and resonate with each other, the world wins, right? So, anyways,
I love that. Well, thank you for, just deep dives on heart health. And it's been such a pleasure to chat with you today.
yeah. Well, thanks for having me. I had a great time.
Yeah, same,
Yeah.
same. And where can everybody find you?
Well, you can find me my medical practice in Sarasota, Florida. I actually Reveal Vitality is the www.revealvitality.com is my website. I actually am the chief cardiologist of a company here in Austin, Texas called Human. So you can find me on their website. And my Instagram is CJ Davis MD. And so you guys can find me there. With Human, we're looking to do some really interesting things coming that I was talking to you about. Really, it's about everything that we talked about today. It's important that we educate the population. And one of my goals is really educating the population about really taking control of their own health. I mean, there's so many things that we can do. And I think there's so much misinformation out there.
Yeah.
That if we can provide some type of roadmap or guidance, I think everybody's health will be better. And so we're actually going to be doing some things that could have some nationwide impact about educating you on a lot of the stuff that we were talking about.
I love that. All right. Well, we'll make sure and put it in the show notes.
Absolutely. Well, thanks
Thank
again.
you. Yes, of course.